gentle maneuvering, I'm already into the esophagus. So when I'm in the esophagus, if you look at the scope is really should be straight, staying straight. And don't rush through the esophagus when you are there. You get there slowly and go through that, because if they have a stricture, that could be a problematic. I assume we have the endoscopic view, right? That's the main thing I'm looking at that right now. So when you get to that G junction, don't start going to the stomach. Take a pause there. See where those folds are going. So I know that this is a fundus area. If I move a little bit to the left torque, that's a fundus area, but I know where the folds are going. I'm just going to gently follow those folds. Gently follow those folds. You see there is some fluid in there. This patient is intubated. So I'm not going to suction that right now. If patient was not intubated, then you want to suction that because there's a risk of aspiration. Clean. So after I get through the stomach, I'm moving towards the pylorus, gently moving. So right there is the pylorus. I have to let this view go a little bit to get into the pylorus. And when I get through the pylorus, I just don't do this movement all of a sudden and then trying to get to the second part of the duodenum. I'll take a pause right there too. Take a look at the duodenal apex and then just follow that gently. Remember that this is obviously a side view. The example I usually give is like you are walking straight and looking at the ceiling. So wherever you want to go, you should not be seeing that. If you are seeing that, that means you are hitting that area with your scope and fast on. So you don't want to do that. So here I'm at the duodenal apex. When I cross that, and from here, I can see the papilla a little bit far. It's kind of a bulky papilla. What I will do is I'll move the small wheel away from me. I can lock it right now because I'm shortening the scope. So I'll shorten the scope. And we can see, we can do the fluoro image right now. So here, you can see the bile is flowing through that papilla. It's quite a bulky papilla. This scope, the quality of this scope is it has a 15-degree backward extra view as compared to 180. So what that does is, and earlier when you were with the 180 scope, if I go there, I would be in this position at that time after I'm fully reduced. With this one, when I'm fully reduced, I can see the papilla completely, upper part of the papilla as well. It's kind of a little bulky papilla. And usually when I'm in the position to cannulate, I don't lock my wheels. I want to have a gentle, nice movement and controlled movement. I will take a look at the orifice itself, where that is. But for me, even more important is what is above the orifice. So I will look at that. Sometimes I even freeze the image to take a look at that. Means I'm trying to study the papilla. And trying to study the papilla is see what conformation is, because every papilla behaves differently. Every papilla has a different shape. I'm taking a look at it, see what would be my axis of cannulation. Here, what I'm doing is I'm taking where the papilla really meets the duodenal wall itself. So that gives me an idea which way I'm going to go with my axis of cannulation. So what I do is, where the papilla upper part meets the duodenal wall itself, that's right in the center of that part. I draw an imaginary line from there to the papillary orifice, and that will be my axis of cannulation. So Gene is he has a visualized wire ready. This is a clever cut. This is Olympus clever safety coating on the cutting wire. And even when it's a portion of it is in the really in the scope, you are at no risk of really causing damage to the scope. So the distant cutting part, and what I do is I show how I caught me. Right now in this scope, one thing you see is you can see an elevator there too. You see that? And in the beginning, you may be a little bit not liking it. I wouldn't say annoyed, maybe a little bit annoyed as well. But you eventually get used to it, and it really is not coming into your view. From here, my angle of cannulation, I already have made up my mind how I'm going to cannulate it. So I'm at the papilla right now, at the end of the scope. I'm going to ask Gene to give me a little bit wire tip, what I call a wire tip guided cannulation. My axis here, I'm going to just cannulation. So from here, this is my line of cannulation. So I'm going to try to maintain that while I'm trying to cannulate it. So obviously we will go right at the, and you can move the scope. And the good thing is, like, you can go a little distal in this scope, a little distal to the papilla, and still be able to see the papilla. So there is a wire tip. It's a little bit position, maybe she's 85 years old, and position is a little bit tricky. But what I'm going to do is I'm going to engage that papilla, move the big wheel towards me, trying to get underneath the papilla, gently moving that sphincter tome, and moving the big wheel towards me. And what I'm going to do is, instead of pushing, I'm going to pull the wheel towards me and ask the, we're going to do the fluoro right now. Fluoro. So we are already in to that bile duct. You can see that it didn't take much really to get in there. As long as your axis is correct, you should be easily able to get in. Now, Gene is going to move that wire further up. Fluoro, can we show the fluoro and endo image, please, together? So even though it's a little bit challenging position, but as long to hold the scope, but as long as you are in the right stuff, Laura, as long as you are in the right axis of cannulation, it becomes much easy and much less painful for all the whole teams, and especially you, and also patient as well. So here we're going to go ahead and inject Flora. So you see there are, the duct is quite dilated. There are flooring filling defects in there. Duct is almost close to millimeter. What I would, if the stone is bigger, obviously I'll do all the sphincterotomy, and then I may even consider really sphincteroplasty on that as well. But let's do the sphincterotomy first. Everything is set up. Bulky papilla, so for me really, the sphincter tome, you can see there is a covering, which is a protective covering. So if I pull the sphincter tome back into the scope, still I'm fine. There won't be any damage to the scope itself. So we'll go ahead and okay. So what I'm in a position cut. There is I'll go start cutting, and when I am cutting, I'll get more space obviously there. Okay, go ahead and cut, and you want to in the direction right center really. So there's a lot of space to cut. I will stop there because I'm getting really close to the wall. Here, if you look at the sphincter now, left side there, cut. If I not much fibers left, there's just a little bit, one touch here, and it's going to be completely open then. And the whole sphincter is cut. I don't know if you can see that or not, but I can imagine it's all cut.